endocrine, adrenal gland disorders, and management and cardiac surgery. Adrenal gland, also known as suprarenal gland, and it is located in the top of each kidney and is composed of adrenal cortex and adrenal medulla. Adrenal cortex produces mineralocorticoids, which include aldosterone, and the function it regulates the electrolyte and fluid homeostasis. Adrenal cortex produces glucocorticoids, which includes cortisol, hydrocortisone, and function is stimulation in gluconeogenesis and increase in blood glucose. It is also anti-inflammatory and anti-immunity function, anti-allergic. Adrenal cortex also produces androgens, sex hormone, and the function in the female is the stimulation of sex drive. In men it has negligible role. Adrenal medulla produces epinephrine, also called as adrenaline. The function, it prolongs the sympathetic nervous system response to stress. And norepinephrine function is prolonged CNS sympathetic nervous system response to stress. So the effects of epinephrine and norepinephrine are increasing cardiac output, increased metabolic rate, vasoconstriction, and increase in respiratory rate. Adrenal cortex, the cortex synthesizes and secretes 30 different steroids, glucocorticoids, mineralocorticoids, androgens. So the famous term salt, sugar, and sex drive. So aldosterone produces salt retention, cortisol, sugar, and androgen, sex hormone. Negative feedback loop. Stress, hypothalamus stimulates anterior pituitary, secretes ACTH and target cells, and adrenal cortex. And then it secretes the specific action and increases the metabolic activity and manages the stress. Cortisol stress is also known as Cushing syndrome. Cushing syndrome can be used interchangeably with the term hypercortisolism. Cushing's disease is the term used for the pituitary overproduction of ACTH. Hypercortisolism can also be from ectopic production of ACTH from carcinoid or cancer, or from overproduction of autonomously in the adrenal gland. Prednisolone and other glucocorticoids use can cause same manifestation. So the cortisol has diurnal rhythm, and the normal secretion of cortisol increases in the time of stress. In Cushing syndrome, the cortisol is hypersecreted without regard to the stress of the time of the day. So etiology is increased secretion of ACTH, pituitary cancer, lung tumors, and prolonged use of glucocorticoid medications for anti-inflammatory disorders such as rheumatoid arthritis, COPD. It could be iatrogenic, caused by the treatment or diagnostic procedures. Females more than males. So the signs and symptoms include adiposity, so fat distribution, moon face, truncal obesity, buffalo hump, thin extremities, increased abdominal fat, and deposition of the adipose tissues can be seen in different places. So patient may have weight gain and sodium and water retention, potassium loss, hypokalemia, and purple stria on the abdomen. So the skin is bruised easily and wound healing is delayed, and there may be osteoporosis and hirsutism. The extremities will show muscle wasting, and boys will have early onset of puberty, girls will have masculine characteristics, and they will complain of fatigue, muscle weakness, deep sleep disturbances, amenorrhea, decreased libido, irritability, emotional ability. Signs and symptoms could be petechia, ecchymosis, decreased wound healing, swollen ankles. Complications: increased calcium resorption from the bone leading to osteoporosis and pathological fractures. Cortisol excess causes insulin resistance and increased hepatic gluconeogenesis and insulin resistance. This leads to glucose intolerance, diabetes mellitus. Complications: frequent infections, slow wound healing, suppressed inflammatory response can mask severe infection. Cortisol is an immunosuppressive agent. Decreased activity to handle stress and psychological problems, that mood swings. Diagnosis: plasma cortisol level, ACTH level, adrenoangiography. Medical management: so early detection is the key, and first goal is to restore the hormonal balance, and usually medications are given. So medical management treatment is based on the causative factor. If adrenal cancer, then surgery. If it is caused by steroid medication, change the regime, and a risk to benefit analysis can be done. Surgical management: if the pituitary gland, hypophysectomy, and if adrenal tumor, adrenalectomy. Aminoglutamide action is inhibits the synthesis of adrenal steroids, and side effects: dizziness and drowsiness, and instruct to avoid activities to need the mental alertness. Ketoconazole action: antifungal, inhibit adrenal steroidogenesis. Diet: high protein, high potassium diet, low sodium, reduces carbs and calories. And management include history and lung auscultation, crackles, edema, and skin integrity, and check glucose levels. She sign of infection during the management in the cardiac ITU. Adrenalectomy: electrolyte imbalance, for hypoglycemia, and prevent adrenal crisis. Administer glucocorticoids. So if the patient is going for cardiac surgery and the patient has prolonged history of having adrenal disorders, then anesthetists need to optimize these patients and consider their pre-op steroid regime, and needs to be discussed with the medical physicians. And sudden drop of hormones, and if the steroids are missed during the intraoperative and postoperative period, then lead to the adrenal crisis. Post-op management of these patients include fluid and electrolyte changes, replace glucocorticoids, mineralocorticoid for the life, and see if disease is bilateral. Addison disease, decrease in cortisol. So there is adrenal hyperfunction and called as adrenal insufficiency, or there could be adrenocortic deficiency as well. So 90% of the gland is destroyed. It could be by the autoimmune disease, and primarily ACTH may be high and secondary ACTH below. Etiology: primary bilateral adrenalectomy, secondary is decreased ACTH from pituitary and hypothalamus, decreased hypothalamus stimulation. Etiology: prolonged use of corticosteroid treatment, and if there is decreased ACTH, decreased hormone release from the adrenal gland, and especially at risk if the drugs abruptly discontinued. So one need to taper the dose in such conditions. So signs and symptoms of this patient is hypertension, lack of aldosterone, sodium and water loss, potassium reabsorption, tachycardia, orthostatic hypotension. Bronze coloration of the skin, hypoglycemia, vitiligo, fatigue and muscle weakness, weight loss, and crave for the salty food. So decreased tolerance for the stress, anxious, irritable, confused, pulse weak, GI upset, nausea and vomiting, anorexia. Complication is adrenal crisis, acute Addison's disease may occur, associated with trauma, surgery, stress, and abrupt withdrawal of cortisone. Adrenal crisis signs and symptoms: sodium and water loss, hypotension, dehydration, tachycardia, IV and administer hydrocortisone. One need to restore the fluid and electrolyte balance and replace the deficient adrenal hormones, glucocorticoids, hydrocortisone, mineralocorticoid like fluorocortisone. So one need to give lifetime steroids, glucocorticoids, hydrocortisone, mineralocorticoids, fluorocortisone acetate, and diurnal rhythm and 2 a.m. to 3 a.m. and 1 to 3 p.m. Diet, one should have high sodium diet, low potassium diet. So the management in ITU include diagnose the patient, fluid volume deficit, it needs to be treated, and there may be decreased sodium level, so one need to monitor and treat accordingly by fluid restriction. And if there is vomiting, it needs to be treated. Increased renal losses and poor skin turgor, weight loss or static hypertension. So ITU management includes the daily patient weight, input and output charting, glucose monitoring, keep an eye on sodium and potassium, skin turgor, orthostatic hypotension. So hyperfunction of the adrenal produces adrenal disease, and hyperfunction produces Cushing syndrome. Signs and symptoms of hyperfunction, that is Addison's disease, is sodium and water loss, and hypotension, hypoglycemia, and hyperkalemia. So potassium would be raised, and in hyperfunction there is sodium and water retention, hyperglycemia, buffalo hump, and moon phase, and potassium would be low. Treatment of hyperfunction is glucocorticoids, mineralocorticoids, restore fluid, and if there is hyperfunction, alter steroid regime or surgery. So ITU management, fluid volume deficit, and if there is hyperfunction, there is fluid volume excess, so one can give diuretics and treat accordingly for glucose intolerance. And in diet, hyperfunction, increase sodium, decrease potassium; in hyperfunction, decrease sodium and increase potassium. Pheochromocytoma. In cardiac ITU, patient may have a variable blood pressure, and post-operative period it would be difficult to control the blood pressure, and patient might be having pheochromocytoma, or there is history of pheochromocytoma, or if it is occurred, then the patient will manifest as variable blood pressure, ups and downs. So one will have a greater difficulty in managing these patients in ITU. It is also known as chromaffin cell tumor, and it's a rare disease characterized by paroxysmal or sustained hypertension, and there is excess secretion of epinephrine and norepinephrine, and it is caused by a tumor, usually right adrenal tumor. Etiology is idiopathic. Stress can be upon attack. So the patient will present as hypertension, and it could be intermittent, unstable, tachycardia, and unrelenting HNAs, and profuse diuresis, palpitation, visual disturbances, nausea, vomiting, feeling of apprehension, elevated blood glucose levels. So patient can have stroke due to high blood pressure, retinopathy due to high blood pressure, heart disease, obviously the heart is overworking, and this hypertension could lead to microvascular damage to the kidney. Surgical management, the treatment of choice is surgery, and remove the adrenal gland, and monitoring of the blood pressure. Pharmacological management is phentolamine or nitroprusside sodium, and control the blood pressure. And diet include increased protein diet, avoid caffeine in some patients, So when they are admitted in ITU, after the cardiac surgery, we need to monitor the BP, monitor the sodium levels, which could be